afternoon, everyone, and thank you for joining us today in our use case, Work, Cancer Care, and Streamlined Public Health Reporting. My name is Shriju Davis, and I'm with Endosoft. Today in this use case, we are going to follow our patient, Axel, who's working with an oncologist to diagnose possible lung cancer. We also demonstrate in this use case how data interoperability works between different systems, such as EHR, pathology lab, backend services app, and state cancer registry using HL7 and FHIR standards to provide best patient care and also to create fast and complete report to the public health agencies. And finally, we will conclude by showing how FHIR standard can be used for death reporting. Endosoft represents in this use case ambulatory oncologist. You can see on the screen our meaningful use stage 3 certified EHR application called EndoVault. Let's take a look at the patient details now. Our patient Axel is a 55-year-old African-American man. He is working in a shipyard for last 20 years as a pipe welder. His history also shows that he was a regular smoker. He used to smoke a pack of cigarettes every day. Although he quit smoking over 20 years ago, due to his work as a welder in the shipyard, his physician recommended lung cancer screening. So Axel comes to see an oncologist to do the lung cancer screening. So oncologist performs a lung biopsy to confirm the presence of cancer. During the procedure, physician collects the tissues from upper right lobe of lungs, and he writes procedure report in EndoVault procedure surgery module with his findings and recommendations. Physician also writes a pathology requisition with the details of the tissue collected. Upon signing the reports, EndoVault automatically sends an HL7 order message to the pathology lab, represented by Shasta in this use case. You can see on the screen, this is the HL7V2 order message that goes out of EndoVault to the pathology lab. The second line in the message, that is PID, contains all the demographics of the patient. The message also contains the details of the test. At this point, Axel's demographics is available on EndoVault FHIR server to be queried by the pathology lab. Axel now completes his first stage of diagnosis, and he is asked to come back by the physician for a follow-up visit in a week or two when the result is available back from pathology lab. Let's pass over to Shasta and see what is happening with the HL7 message that was sent over to the lab.
Thank you, Shiju. Good afternoon. My name is Katie Warner with Shasta Networks. Shasta's interoperability engine Ascent lies at the center of the EHR, the pathology lab, and the state cancer registry to provide automated, complete, and timely reports to the registry. The oncologist pathology specimen order is passed from the EHR through Ascent to the pathology lab via an ORM HL7V2 message, as was seen in the previous slide. At this point, Shasta creates the patient object in the FHIR server. The pathologist results the specimen with the CAP electronic cancer checklist, or ECC, and the structured results for the resection and biomarker are passed through Ascent to the EHR via an HL7V2 ORU. As is often the case with outsourced pathology, the results are missing multiple key demographic elements that are vital for cancer research. Upon receipt of the ORU, Shasta validates the message against the state's conformance profile. And now we're going to take a look at Ascent's Validate module to visualize where we are missing information in the message. We're going to scroll down to our location map visualization for required entity not received. And since we're focused on demographic information, we're going to narrow in on the patient ID or PID segment and update our visualization. And what you're looking at is a map, location map of where we're missing elements in the message. And it's at different levels within the PID segment, where the center ring is the segment itself, moving out to field and components and repetitions. Focusing on the field level, we can see we're missing information in the MRN for PID 3, the name in PID 5, the address in PID 11, the ethnicity in PID 22, and the phone number in PID 13. Patient contact information is essential for state registry when contacting the patient is required, and elements such as gender and ethnicity are needed for research, as well as for possible identification for clinical trials. Shasta will utilize the FHIR connection to the EHR to query for the demographic elements and then update the patient object. This can also be achieved by stitching together multiple V2 HL7 interfaces to provide a completed report, as is currently in production in California. And now I'm going to pass it to Shiju to discuss the diagnosis.
Thank you, Katie. Now, Axel comes back to the oncologist for the follow-up visit. An HL7 interface running in the back end of EndoVault receives the result back from pathology lab. The interface parses the data coming back from pathology lab and updates EndoVault for the physician to review. So what you see on the screen now is the result that came back from pathology lab. So one of the results that came from pathology lab is the biomarker test, and the second one is the biopsy result. Physician reviews the results and he confirms the tumor in the lungs. The tumor is of size 1 centimeter approximately. So oncologist then creates a follow-up note in the system with a treatment plan. He also updates the diagnosis codes in the system. So in this particular use case, we use ICD-10 code, that is C34.11, to report the cancer to the registry. When the report is signed by the physician, EndoVault sends a notification to the backend services app represented by Morph to let them know that there is a report available for this patient with the treatment plan. We will see later in this use case how Axel's data will be used by the State Cancer Registry for clinical trial. EndoVault also has a built-in oncology module that helps the oncologist for the further cancer treatment. Now, passing over back to Shasta, and let's see what they do with the diagnosis code that we send over. Thank you.
Timely reporting is of the essence for state cancer research. Manual identification can take as long as 6 months to report to the registry. In this time, the patient's contact information may have changed, or sadly, the patient may have passed away. To automate this process, Shasta will utilize the FHIR connection to the EHR to query for the diagnosis on an hourly basis. As soon as the oncologist enters the diagnosis, the ICD-10 code will be returned. In this case, we see the diagnosis of malignant neoplasm of upper lobe, right bronchus, or lung. Shasta compares the ICD-10 code to the table of reportable cases, and this is identified as a reportable event. Then Ascent packages together the ORUs in an HL7 FHIR bundle and pushes it to the state registry. And now we're going to push it to Morph to discuss their back-end services app.
Thank you, Katie. I'm Maria Michaels from the CDC, representing the Morph team. So, as you've just heard, in addition to taking care of the patient clinically, data needs to be submitted to state cancer registries for cancer case reporting and to CDC's National Center for Health Statistics, or NCHS, for healthcare surveys. Morph extracts data from the EHR, repackages it, and sends it to the appropriate destinations. A little bit more about Morph's approach. It uses a back-end services app that runs in the background. This means there are no workflow interruptions for clinicians. It utilizes the FHIR standard and can run on any EHR system. In this scenario, FHIR is used for interactions with the EHR, such as notifications to and queries from EndoVault, as well as sending information to other entities like the State Cancer Registry or NCHS. Another important component is the Knowledge Artifact Repository, which houses trigger codes, value sets, rules, and other artifacts needed for the backend services app to know how to apply a particular use case. Common workflows for multiple use cases include provisioning, notification, data collection, report submission, and response or acknowledgement. I'll also note that the backend services app shares a technology base with the Electronic Case Reporting's ECR Now app. In fact, ECR Now is the backend services app for electronic case reporting. A little bit more of an overview of the project. The reference architecture is designed to handle needs across a variety of use cases. The reference architecture implementation guide has been validated and approved at HL7. Content implementation guides are developed for specific use cases, and those begin with referencing the reference architecture implementation guide and then reuse existing profiles where possible, such as US Core. Content implementation guides are in process for cancer reporting and for healthcare surveys. But existing content implementation guides can also use the reference architecture. So for example, chronic hepatitis C surveillance is using the electronic initial case report implementation guide for content and the reference architecture implementation guide for data exchange. There's also a research data exchange implementation guide designed to enable gathering and querying at the population level using FHIR. A little bit more about the functional role of MedMorph in this scenario. Trigger codes from the Knowledge Artifact Repository are subscribed by the EHR for both cancer reporting and healthcare surveys. Based on trigger codes documented in the EHR by the clinician that identify an initial diagnosis of cancer and the physician's participation status in a survey, in this case, the National Ambulatory Medical Care Survey, Endevault notifies the BSA of a patient encounter, and the BSA queries Endevault to gather information. It then prepares and sends information for delivery to endpoints, which in this case, or the cancer use case, is a report sent to one or more state cancer registries, and for the healthcare surveys use case, a report is sent to NCHS. And you'll hear more about the healthcare survey in step 7 of this scenario. A response is then sent back from the state cancer registry and NCHS respectively to let Endevault know that the report has been received. And now I'll pass it on to the state cancer registry to take us through the next step.
Thanks so much, Maria. Hi, my name is David Jones, and I work with the National Program of Cancer Registries at CDC. For the purposes of this demonstration, I'm acting as the State Cancer Registry. All state cancer registries have state laws requiring various healthcare providers, including doctors, pathology laboratories, and hospitals, to submit cancer reports for every patient living in their state who is diagnosed or treated with cancer. As you've seen in this demonstration, both laboratory and physician reports related to Axel's cancer diagnosis and treatment have been sent from the pathologist and oncologist. I am demonstrating the State Cancer Registry's ability to receive and process these reports using the CDC FHIR developed FHIR endpoint and eMark Plus integration tool. eMark Plus software is made freely available to all state cancer registries. We received reports from the laboratory, represented by Shasta, that provide patient information including diagnosis. The pathologist used the College of American Pathologists IHE structured data capture form, which submits HL7 FHIR resources, including observations. The first report is the surgical resection. Here, as you can see, this is the HL7 FHIR payload that contains the pathology data. And on this next screen, we actually have parsed out data from the HL7 FHIR payload. The resection biopsy resulted with a diagnosis of non-small cell carcinoma in situ of the upper lobe of lung, as can be seen here. The CAP biomarker report is used by the pathologist to document the EGFR test that was performed, which in this case, as can be seen here, was found to have a positive mutation. Cancer registries use the positive pathology reports to provide initial incidence data and will alert the registry that additional case information will be forthcoming from other sources. We also received the patient report from the ambulatory oncologist, in this case represented by Endosoft, which used the MedMorph backend services app. As you just heard from Maria representing the MedMorph team, this report was identified as a new reportable cancer case through the MedMorph triggering mechanism. The value to the cancer registry of receiving this particular report, in addition to the pathology report, is that it provides the information about Axel's occupation, in this case, as can be seen here, of being a pipe welder in the shipyard industry, which ultimately led to his early diagnosis, as well as treatment information for the treatment that he received. In this case, some chemotherapy and immunotherapy. As you can see, state cancer registries often receive data related to the same patient from many different sources. As a result, cancer registries need to perform consolidation, where they pull together the data from all of these different sources into a single record for every cancer. Reports are exported out of eMark Plus and imported into the state's central database, where this consolidation process occurs on a regular basis and must be done before the cancer registry sends their data on to CDC. Once a year, these data are compiled, consolidated, and processed at each state cancer registry, and the de-identified data are transmitted to the CDC National Program of Cancer Registries. CDC provides national level data on this website, the United States Cancer Statistics, and allows the public to access databases for research purposes, as well as publishes articles based on national data analyses. As you can see, this tool is very interactive. As you highlight or move your cursor across multiple states or even click on the states, you can see immediate statistics, such as the rates of top 10 cancers in that given state. One thing you'll notice, though, is that the data that's most recently available is from 2018. Implementation of the standards and solutions that we've presented here today will provide more complete and timely data for use. Now I'll turn it over to Dr. Dennis Deepin to talk about how the cancer registry data can be used for clinical trials.
Thank you, David. Electronic cancer pathology reporting offers many advantages for public health beyond documenting the diagnosis. An intriguing opportunity exists to transform patient notification and recruitment for participation in clinical trials. Clinical trials are the gold standard for assessing the efficacy of treatment protocols. Yet fewer than 10% of cancer patients participate in clinical trials, and minorities and the economically disadvantaged are underrepresented. In 2016, the California Clinical Trials Program was passed by the state legislature. With transmission of cancer pathology reports to the Department of Public Health within 2 weeks of diagnosis, this creates the capacity for an automated matching with eligibility criteria of all active clinical trials, and the patient's healthcare provider can be immediately notified. However, the traditional path report lacks some key data to make this determination. These data do exist in the provider's EMR. What is needed is for data integrators such as Shasta to install a system that automatically connects these required data items for submission with the electronic pathology report. And now let's pass it on to the National Center for Health Statistics.
Thank you. My name is Prachi Mehta, and I'm with the Division of Vital Statistics at the National Centers for Health Statistics at CDC. And this afternoon, with my colleague Veronique Bene, we will be tying in this use case and data flow in the context of the National Ambulatory Medical Care Survey and the National Mortality System. Since Axel's oncologist is participating in the National Ambulatory Medical Care Survey, also known as NAMCS, his encounter-based demographic and clinical data in the form of a NAMCS healthcare survey report is received by CDC's National Centers for Health Statistics. Axel's data is compiled with thousands of other patients' data, rigorously de-identified and made publicly available through web tables and public use data files. These nationally representative data are used by health service researchers, federal statisticians, and healthcare industry stakeholders. The uses of these data include data to inform trends in cancer-related physician office visits in the United States and healthcare and medical journal articles. Shifting from the National Healthcare Surveys reporting to mortality reporting, the next part of our story discusses mortality statistics. Axel is cured and lives a long and happy life. However, in the United States, cancer is the second leading cause of death, exceeded only by heart disease. Having quality mortality data is essential for public health policy and programmatic decision-making. Within NCHS, our Division of Vital Statistics collects and disseminates the nation's official vital records that includes information on births, fetal deaths, and deaths. These data are provided through contracts between NCHS and the jurisdictional vital records offices, who are legally responsible for the registration of vital events. To help move things forward, DVS supports an e-Vital Standards initiative, which enables the development of vital record standards to support interoperability between the electronic health records and the state vital record systems, as well as national vital statistics systems and potentially other public information systems for vital records. Shifting back to today's scenario, this image shows the flow of the fire death message being received. So NCHS receives the HL7 fire death message from Michigan's electronic death registration system. NCHS then takes the HL7 fire death message and parses the message, loading the message into the NVSS database, where the coded cause of death and race and ethnicity output files are created. NCHS will take the cause of death file and run it through our automated cause of death coding system, which in turn will generate an ICD-10 coded cause of death, which will be sent back to the state. The following are some examples of areas that are still in the development stages for NCHS. These are some of the processes that we have tested so far. This diagram shows the literal text on the cause of death that was processed within our system. These images show the return fire message on coded cause of death. The ICD-10 code generated for lung cancer is data from Part 2 of the death certificate or the significant condition contributing to death. The three other ICD-10 codes you see here include ICD-10 codes for acute respiratory distress syndrome, pneumonia, and COVID-19, with COVID-19 being the underlying cause. The fire message containing the ICD-10 codes causes of death will now be sent back to Michigan. Before handing the story over back to Michigan, we wanted to leave you with a few national level statistics. This visualization provides weekly estimates of excess deaths by the jurisdictions in which the death occurred. Excess deaths are defined as a difference between the observed number of deaths in specific time periods and expected number of deaths in the same time period. Estimates of excess death can provide information about the burden of mortality reporting potentially related to COVID-19 pandemic, including deaths that are directly or indirectly attributed to COVID-19. In conclusion, the availability of coded cause of death data for epi research and interventions has historically been several years after death. New approaches for near real-time coded cause of death determination using FIRE, as we have seen in this example, can monitor the health of populations and enable earlier interventions. I'll now hand it over back to Michigan, who will be receiving the coded cause of death and coded race and ethnicity from NCHS. Thank you.
Thank you, Prachi. I'm Craig Newman from the Altarum Institute, and we're representing the state of Michigan Cancer Registry. We've just heard that the NCHS will return coded causes of death back to the state EDRS, so that this data can be added to the decedent's record. It's then important that the EDRS is able to share this data with other public health programs who may need death information for their own purposes. In this part of the demonstration, the EDRS shares a bundle of FIRE resources with the State Cancer Registry. This bundle contains data on the decedent, including the relevant IDs, their name, and other demographics which may be used to match the contents of the bundle to a cancer patient. The bundle will also contain death certification information, including the coded causes of death and other contributing factors. As well, the bundle may contain usual occupation and industry data for the decedent. Upon receiving this FIRE bundle, the Cancer Registry will parse the data and attempt to match the decedent in the bundle with the patient in the registry. It's important to incorporate data from the EDRS into the registry so that comprehensive data can be compiled on all cancer patients in the jurisdiction, and so that if a patient expires, it's possible to know if the cause of death was cancer-related. If a matching patient is found in the registry, the patient record would be updated with an indicator that the patient is deceased and with the coded causes of death and contributing factors. But what happens if a matching patient is not found? Then, if the cause of death is cancer-related, the registry can be updated with a new case for the decedent, including the coded causes of death. There are a number of reasons why the patient may not already be in the cancer registry. The patient's death may have occurred before the case could have been reported to the state registry, or the patient may have been out of state at the time of diagnosis or treatment. But regardless of the reason, it's important to capture these patients in the registry. Once the coded causes of death have been integrated into the cancer registry, that data can be used in a number of ways. First and foremost, it's important to be able to understand if the cancer diagnosis either caused or contributed to the death of the patient. But the data can also be used by researchers for purposes such as investigating patient survival rates after treatment, or to isolate the impact of specific factors such as COVID-19 on cancer patients. States can also use information about occupation and industry to assess cancer risks in their populations. The use of FHIR to establish a near real-time exchange of data represents a significant improvement on the current timelines for getting data to researchers. And finally, cancer registries can use this data to ensure that they're sensitive to the emotional needs of the family of the decedent, making sure that they don't attempt to follow up with the patient or try to recruit the patient into studies after they've passed. While not all of what we've described here has been fully implemented, even in jurisdictions where the cancer registry is located in the vital records area, FHIR shows great promise for increased sharing of timely and high-quality vital records data with the cancer registry so that it may function more efficiently and effectively. And this concludes the demonstration. We thank you for listening.